lecture to you. It is going to be a co-presentation between two speakers. So I will be giving a bit of an abbreviated introduction to both of these speakers in the interest of time. So the next lecture is presented by Dr. David Jadwin, and as well it's going to be co-presented by Elliot Fieldhouse Allen. So Dr. Jadwin is the president of Columbia Healthcare Analytics, which he founded to provide educational feedbacks to physicians about their case management. David is a fellow of the College of American Pathologists and has served as department chair for a number of hospitals. And he has a career that spans back to 1968, where he started out as a medical lab technologist, then obtained his graduated in biochemistry before receiving his Doctor of Osteopathic Medicine. Then he completed his anatomic and clinical pathology residency in San Antonio, Texas. He's also had a career in emergency medicine as well. So David has published a very pinnacle article, Determination of Unnecessary Blood Transfusion, which was a comprehensive review of 15 hospitals. And this was done in the Joint Commission Journal on Quality and Patient Safety. And now a larger study with 53 hospitals and hundreds of thousands of patients is being conducted. And I'm hopeful that we'll hear a little bit about that today too.
Thank you, Becky, and the Society for inviting me to speak today. I don't know if Elliot will be able to talk during this session. He may present later in the week. It's still under discussion, but let me share my screen with you. Well, hopefully you can see everything here. So my talk today is about, and I spoke in May a little bit about this as well, but it's about patient blood management analytics. And as far as any disclosures, I am the president of Columbia Healthcare Analytics. I have worked since 2006 without any compensation, so I have no financial conflicts, and Elliot will speak about his. So our objectives today, going through these fairly quickly, is that why computerized physician order entry needs to be improved. We'll discuss some data measures of avoidable blood use. We'll talk about a study that we're doing right now and hope to be beginning an intervention study to show how we can rapidly change physician behavior, how to better report blood use and particularly patient blood management, and some applications of artificial intelligence in healthcare and patient blood management, which Elliot will talk about probably later this week. The purpose of the data is to show physicians that most patients can be managed without blood use. That's really the key focus here. So as was mentioned, we did publish a study last year, a 15 hospital study, where we reported that 45% of patients, plus or minus 15%, could have been managed without transfusion of any type. And these largely stem from the use of laboratory criteria such as hemoglobin less than 7 or an INR greater than 1.8, which are not indicators of good blood management. That's just a level below which you can transfuse, and we probably won't look at what you're doing. Unfortunately, hospitals have gotten away from doing any chart review, and they've gone to dashboard metrics such as the percent of patients who have a hemoglobin above or below 7. And there's nothing magical about 7. So what are some of the basic principles of good patient blood management? Well, the first is to control or stop the bleeding, timely clinical and laboratory evaluation. You can't believe how many times people don't get an anemia workup until after they've received a half a dozen units of blood. Optimize the patient, looking at anemia and coagulopathy, evaluate the patient and provide good documentation. When I look at thousands of charts, the indication in the progress note is the patient's anemic. I mean, that's all they document. Individualized patient management. Don't just respond because the hemoglobin is less than 7, and be conservative. In other words, don't rush to transfuse. Oftentimes you can wait 12 hours, 24, 36 hours in many situations. And finally, the current CPOE, such as a hemoglobin less than 7, are not measures of good blood management. They don't tell you whether they could have corrected the anemia, 3 weeks ahead of time. So if these CPO indicators aren't that great, what are some of the ones? Well, we advocate really 3 attestations that the physician has to do. So they're not checking the hemoglobin is less than 7. They're saying, number 1, life-threatening bleeding is present, and they're attesting that non-transfusion modalities have been implemented, hemostatic, pharmaceutical, cell salvage, etc. These are far less than 5% of all cases. The second category is patients with severe anemia impacting organ perfusion. And the physician will attest that timely anemia workup has been implemented, not performed, and timely IV iron and erythropoietin-stimulating agents have been initiated. And the third one is that there's a significant risk of significant bleeding from coagulopathy, and they're going to attest that timely pharmaceutical treatment has been initiated. So instead of checking the hemoglobin's 6.9 or less than 7, they make these attestations. And there's a final caveat: if it is a surgical patient, then they're going to attest that pre-admit preoperative anemia has been addressed, timely non-transfusion modalities are employed, and appropriate testing has been completed. So as was mentioned in this 50-plus hospital study, 16 health systems, 350,000 patients, a very simple study. We're looking to see how much has blood use changed between 2016 and 2023. We have many hospitals, we have data going back to 2009, but not all the hospitals have that. So we segregated 2016 and 2023, and we also broke those down into pre-COVID, COVID, and post-COVID sets. So this is a very simple study looking at just the discharge hemoglobin in patients that received a red blood cell, looking from 2016 to 2023, and seeing how much has the median discharge hemoglobin confirmed. Now we're just in the middle of doing the biostatistics on this. It's probably going to be ready for publication just in a couple more months. But I think you can see the median hemoglobin is around 8.5. It really hasn't changed much, other than some variation during COVID. Same thing for patients who got a total of 1 or 2 units of RBCs, around 8.5. That means half the patients have a discharge hemoglobin above 8.5, as you'll see sometimes up to 16, 17 grams. So that was a monthly run chart. This is the annual chart, so you can see the annual variations here, and you can see that the slope is very slight. I think it's improving like 0.1 gram per year as far as reduction. A lot of this has been actually more since COVID. So that's the median discharge hemoglobin. So let's look at the patients who had a discharge hemoglobin above 8 grams, and 8 grams is rather high. Look at the percent of patients who would be over-transfused, hemoglobin is above 8, and you can see it's around 80% for all RBCs, 1 unit and 2 unit RBCs. Again, the drop here is probably a little bit more towards COVID rather than as a response. So we can then calculate what we call the median transfusion-free index, which is we're going to take the discharge hemoglobin, we subtract the hemoglobin they receive from RBCs, 1 gram per deciliter, from the discharge hemoglobin to get a crude estimate of where the patient might have been without RBC transfusion. And we can see here that about 40% plus of patients likely could have been managed without RBCs, just based on the discharge hemoglobin alone, without looking at missed opportunities to treat anemia or diagnose anemia, control bleeding, etc. For 1 unit, it's about 80%, and for 2 units, it's about 40. Well, it started at 60 and went down to 40%. Now, in our paper, reported that if patients got 1 unit of blood, when you did a complex chart review, page by page, vitals, labs, medications, etc., 90% of the time they didn't need that single unit. And if they got 2 units of blood, 60% of the time they didn't need those 2 units of blood. And here we can see, just based on this, it's about 40%. This just shows how we can compare hospitals. So this is a large academic hospital, and we're looking at the median, a monthly run chart, the median transfusion-free hemoglobin for all RBCs. You can see they're substantially above the median curve for the group. So what is acceptable performance? Well, this is a large 800-bed hospital. This is over-transfusion for all RBCs and 2 unit. We don't use 1 unit because if they didn't need the 1 unit, that's not particularly over-transfusion. So you can see that there really hasn't been much of an improvement over a number of years in this hospital. Now we can look at the transfusion-free run chart, and this is 1 unit transfusions, 2 unit, and all RBC transfusions. You can see really there hasn't been much much of an improvement. So what is an exceptional, what's an acceptable level? Well, here, this is very interesting because this is the only hospital that we've seen this impact where they actually had a reduction in their blood use back in the 2015 and has steadily increased ever since then. And this is so long ago, no one even remembers what they actually did here. So it's unfortunate. But it does show that it is possible to get down to 25%. It's probably unrealistic to think that this will ever go to 0 or even 10%, but it does show that you could get this down to around 20%. And so what we want to do is we've applied for some funding to do an intervention study where we actually pay the physicians to participate because physicians are so busy they don't want to even look at anything. So they'd actually be paid to look at their cases and see. When we show them the data, we talk to them, we give them their own case feedback to see if we can bring this curve sharply down here. And we're actually applying for a fairly large grant in Africa, taking this technology, not just for blood use, but for healthcare in general, using artificial intelligence. And we're coupling that with the LA County Health System and hopefully others as well to take cost savings from LA County and to send 10% of that back to other low and moderate income countries. So this is another study we just did. This is just 19 months for the most recent study. This is one of the hospitals we have data going back for to 2009, but it's a 500 plus bed hospital, 19-month study. And this is just looking at the transfusion-free discharge hemoglobin for 1 or 2 unit transfusion. You can see they did around 7,500 each, about 15,000 units. And these are the bins for the discharge hemoglobin, say from 7.1 to 7.5, 7.6 to 8, et cetera. And you can see the extent of over-transfusion here, the blue being perhaps the ones that may need transfusion, although I think if many of these patients are Jehovah's Witnesses, they'd probably do well. And of course, this translates into a lot of money, around $5.5 million over 19 months. Now we can take, if we have physician-specific data, we can actually create a scorecard. So I know that some people look at the pre-transfusion hemoglobin for people, which I think it has some limited value for a lot of reasons. But I think it makes more sense to look at the discharge hemoglobin. So this is a physician, the top one, they had 169 physicians, the top transfusing physician, 192 patients over 19 months, or about 10 patients a month. He had 88 1-unit encounters and 46 2-unit encounters, or 82% of patients got 1 or 2 units. What does that tell you? That a high percentage of those patients probably could have been managed without transfusion. Then you can look at their median hemoglobin for 1 and 2 units. So in this case, it's 8.1. So half these 1-unit transfusions had a hemoglobin, transfusion-free hemoglobin above 8.1, and for RBCs equal to is 8.7. And then you can look at the percent of patients who likely could have been managed just based on the discharge hemoglobin. In this case, it was 68%. Down here, it's 85%, 85%, 92%, et cetera. So we can look very quickly to see who are the heavy hitters. And by the way, out of the 169, there are probably about 90 physicians that transfuse less than 5 units of blood over 19 months. So some question could be if those physicians should actually be prescribing blood, because they do it so infrequently. So in this study, anyone can participate. We're hoping that maybe some people will contribute. It doesn't cost anything. It takes very little time. It doesn't take time from your blood bank or your laboratory work with discharge procedure reports. It's anonymized, so we don't need any patient identifiers. We look at data going back as far as we could, even 20 years if possible. We're just looking at the discharge hemoglobin, the admission hemoglobin, if available, the various components, the admission, discharge date and time, the age, gender, discharge status or disposition, the primary diagnosis, hospital service, and then the ordering physician identification. So finally, how should patient blood management and blood use be reported? And I can't tell you how many various blood use committees I have sat in on. And the most recent one, they spent about 40 minutes just talking about the components transfused, the components wasted, outdates. And whole blood hemostatic testing. There's nothing wrong with hemostatic testing, but the amount of blood that this is going to save is relatively small if most of these patients are getting 1 and 2 units, and that's constituting at least 50 or 60% of the units. So it really makes sense to look at these small things. But these should be, as a pathologist, I've sat on these for decades, and this should at most be information, and probably not more than 3 minutes. In fact, you can probably just send this information. If it has an assessment and a plan, you can probably just distribute these to people, and then if there's any comments, they can add that even by email. The second phase of this is really looking at your adverse transfusion events, the serious and the minor ones. Again, these are informational only. If you have a serious one, they probably should have a casework and not necessarily a discussion at the committee. If they need a chart review, that probably should be done offline, and then a plan. But this is where the real nuts and bolts are, is looking at the transfusion and patient blood management. In all the committees I have sat in on, they hardly ever touch these things, such as the massive transfusion events, the number, and their outcomes. They oftentimes leave out the outcomes. Prospective transfusion interventions, which I think are pretty cavalier. Most people get if they say they have a bleeding, GI bleeding or this or that, they usually get approved. When we look at these after the fact, they almost always are unnecessary. Appropriate anemia workups, pharmaceutical reports, which is often not done. Again, the RBC1, 2, and et cetera. And then this you can read online, but these are some other comments about how to run a blood usage committee. And then finally, it is possible to review charts in a matter of minutes now, and you can actually count the number of times that a patient might have been a candidate for iron studies or anemia workup, in this case, 28%, patient a candidate for IV iron, 18%, patient candidate for IV iron and or with their potent, 17%, so 35% of patients right there. Additional IV iron, 7%, and earlier IV iron, 6%. When you add all that up, you can see this. So that's pretty much this point. I think Elliot will probably speak later this week. And so I hope we've covered these objectives adequately, and that the purpose of this data is really not to tell physicians what to do. Everyone tries to tell physicians what to do, and I've heard a lot of academic pathologists, et cetera, say they really, and even surgeons say, you know, I try to go around tell doctors, they just don't want to listen. So if you can take their data and show them instances why they are over transfusing, you have a much more powerful tool to change physician behavior than just trying to do educational sessions. Thank you very much. Any questions?